How
I
about
can
now?
see your, yeah, go ahead and do the slide. Okay, again, Dr. Shahady is the medical director of the Florida Academy of Family Physicians Foundation Diabetes Master Clinician Program. He's well known to many family physicians for his expertise in managing diabetes, and we are so honored to have Dr. Shahady be part of our Go Diabetes project this year. He has brought, as I said, expertise, enthusiasm, and a phenomenal knowledge base on handling patients and managing patients with diabetes. And we're happy to have Dr. Shahady present today on how a diabetes registry improves quality, decreases cost, and enhances team care. And again, just as a reminder, if anybody's joined us, your phones are on mute at this point in time. We will have an opportunity for Q&A at the end of this. Dr. Shahady?
Well, hello, everybody, and thank you, Susan, for such a nice introduction. It's a pleasure to be here and share some of my excitement about diabetes and diabetes quality and how we can improve it in the office setting. The objectives for today's presentation are first to understand what's the value of measurement and on the registries, and then to demonstrate how it's part of PPACA and the PCMH. And I'm sure PPACA is not a term you're used to, but that's the Patient Protection and Affordable Care Act. It's the health care reform, which is associated with the patient's name. I don't want to do that. I want to put it in the context of what it is, patient protection and accountable care, and many of the aspects of that which value measurement, quality, transparency, and the patient medical home, and that's what I'll be talking about. Understand our reports and our registry from our Florida Academy of Family Physicians Diabetes Master Clinician Program, and then understand why team care is so difficult. And that probably, everybody says, well, we do team care. Well, I'm going to say you don't, and I hope you prove me wrong. I'd love to come to your office and see your team functioning, but I've been around over 150 offices in the last 7 years, and I don't observe it. I think it's very, very difficult to do because it's not intuitive. It's not part of our DNA. We haven't been trained to do it. In our residency programs, unfortunately, I don't see it demonstrated there. I see a few examples of how a participatory office team can improve diabetes quality goals and increase cost savings, and orient your thinking to systems, population-based solutions, and empowering your staff. So measurement, what is it? Does it really matter? Most of our experiences with measurement are with managed care companies that tell us whether we're an outlier or not, and we look at it as are we good or are we bad? So it's judging your performance, and that's not what we want to do. We do not want to say, because I'll show you measurements from actual practices here in a second, and I don't want to say they're good, bad. It's where they are at this point in time, and it gives them a framework on where they can go. It's what data does, measurement does, is identify the processes or systems at a point in time that you might be able to control and you can change. It's not the data is there to evaluate you. The data is there to help you manage, help you do what you want to do. If you want to make those numbers different, you can do that because you have them. You don't know where to go if you don't know where you are. And you can see the quote there. This is from recent data in health affairs. Now, here's one of our registry reports. So if you look here, this practice, the ID, they actually have over 2,000 patients. You can see how many have an A1C, have an LDL, have a blood pressure, and how many have all three. Some patients don't have all of them. Something fell through the cracks. But we have reports to let you see not how they fell through the cracks, but to prevent the cracks. And then you can see what all of our clinics. Actually, we have, this was probably about 2 weeks ago, 3 weeks ago. We have more patients than that now, over 19,000. But this is what all of our clinics do, 57, 60, 57, 23. So you get a good idea. And then these numbers here, you can see eye checks, and This is documented in the chart, an eye check. It may have been done, but it's not documented. So for all of our clinics, it's 28%, which are over 104. For this particular one, it's 17%. For their foot checks, 27 versus 40. For your microalbumins, 32 versus 40 for everybody else, 62 versus 54, and 20 versus 30. So again, this is not an evaluation of this practice or its individual physician. It's evaluation of the systems, because I clearly said documented. Sometimes things are done and not documented. And we have specific rules that foot check means was a monofilament done. And eye check means that there was a professional eye physician, optometrist, and ophthalmologist that did a dilated eye exam, which is the standard of care. So we try to stick with standard of care. So this practice knows that. I'm going to show you one more. What I meant to here was supposed to show you the number of people at goal for this, and I think I do that in another time that I show this slide. So why do we need registries? Patients need information about the quality of care doctors and hospitals provide to make informed choices about care. And you can see where I got this from. Recently, National Program Office for Aligning Forces for Quality, RWJ National Program, and this is from George Washington University Medical Center. They published this. Doctors and hospitals need information, identify areas where we want to improve, and that's why, we're doing it. Consumers and purchasers need information. This is sort of scary, but why shouldn't people know if they want to choose a doctor, take care of their diabetes, how well that doctor does in achieving quality diabetes care? In Minnesota, if you go online and look at health grades, you will see that you can see how well a physician is doing in reaching goal for A1C, LDL, and blood pressure. So why shouldn't a patient know that? Now, I know many of you are saying, well, what type of patients do you have? Because if you're in a safety net clinic, your numbers are not going to be as good. Take away the word good. They're not going to be what they would be if you're in a practice that has patients that are all well insured. So you have to say, where were they in the beginning and how are they improved? We have some homeless clinics that have shown significant improvement. We have one that's now up to 60% for their reaching goal for A1C. I just was with them yesterday. So it can be done. They're not going to be able to reach the higher numbers, but they can improve on what they're doing. So how does a registry aid you're developing a medical home? Well, first of all, let's look at what we are, what we're doing. We've been doing this since 2003. We have a lot of docs in their offices or medical assistants who've been trained to use the program. You can see what our total number of visits and patients is. We enter all diabetic patients into an internet-based diabetes registry. We have grants to help us pay for doing that. And some of these practices are Go Diabetes practices, and the Go Diabetes Project paid for data entry as well as what our internet registry and my teaching. We generate reports that save time, help with patient self-management. They measure performance compared to standards, identify patients not at goal, empower staff, and facilitate becoming a medical home. Why diabetes? Why did we choose diabetes? Well, pretty clear. Diabetes is the poster child for medical homes, and the reason is that, excuse me for a second, I got a little bit of a frog in my throat. Evidence documents that when patients achieve control of their A1C, LDL, and blood pressure, and other evidence-based activities, we get reduction in complications. You're all familiar with the BCCT trial, the UKPDS trial, other trials that have shown if we get those numbers to less than 7%, less than 100, down around 130 over 80, we reduce heart attacks, strokes, blindness, kidney disease, etc. So we have excellent evidence and also cost savings evidence if patients reach goals. So why our reports? Because we now know, and I'll show you the data, practice that measure individual and practice achievement of these evidence-based activities, ensure that information with clinicians, staff, and patients achieve better diabetes control and reduce cost and complications. Now, here's our first report that we're given. This is to the patient, and you can see this, and I'll blow it up a little bit. You can see it better. This shows these parameters, which we measure in diabetics, what the goals are, and where that patient is. And this one is given to the clinician before they go into the room. Also notice we measure non-HDL, which is probably a better indicator than LDL of residual risk. And we need to get that goal anytime a triglycerides are over 200, or if we really want to get residual risk down, the LDL reduction to down less than 70, you still have a 40% residual risk. So getting the non-HDL down helps a lot. And here's what else you have. Again, this is the clinician has this before they walk in the room. All the information is in one place. You don't have to replicate the chart, the electronic chart or the paper chart to find it. It's sitting there, and you can manage that. This, of course, these dates wouldn't be correct now, but at the time this report card was generated, this is where that patient was. Now, where does the patient know where they are? Because we've got to empower the patient, and this is our other report. It's given to the patient by the staff, empowers the patient. It also tells the patient our staff's important, and it helps with the medical home requirement of self-management. Let's blow that one up a little bit, and you can see some of these things. I'll highlight those for you. And you can see A1C, and we're putting that in patient words. The LDL, lousy or bad cholesterol. HDL, happy. Eye checks prevent blindness. So these are all words the patient understands. It tells the patient how often they should be done, and it tells them, you know, if it's most recent test and when the next test is due. So we're empowering patients. And we know if we give patients this report card, they're much more likely to achieve these goals because they ask questions about them, they understand them. They say, why haven't I had a foot check? And also the staff then can help you get ready for that foot check and remind you. So they're our partners. Now here, I'm going to go back to this one again and put up the national data because this is this practice. Because what I want to show you is if 50% of these patients, they had 61% at goal, but if 50% were at goal of the 1993, it'd be over 900 or so. So we subtract that from 1213, and we can start looking at that many patients over a national goal, 216, I think it is, achieve that goal above national average. What was the cost savings? Same thing for LDL, 40%, same thing for that. I'm going to show you in a second cost savings. So I want you to know how I got those numbers. And I'll tell you where that data comes from. And this is all their other numbers that we previously looked at. Now, how was the practice? Let's look at the individuals. Now, you know, here they were, all of them, you know, 31, 23, 66, 61, and clinician 406, 60, 65, 54, 408, and so on and so forth. But look at clinician 432, 70%, 75%, 70. Wow. And this clinician had lots of patients. In fact, I followed them for over 2 years and seen he's actually attracted more patients. I asked this clinician why, and he just said one word, Sandra. Sandra was his medical assistant, his nurse, who helped him. So team. We can't do this alone as clinicians. We have to have a team. We have to model that in our teaching programs, and we have to show residents and students how to be effective team members. And that's a different behavior. We're used to being in charge, being the one that says what to do. And what I found out is Sandra and other medical assistants I've talked to, very effective, was calling a lot of the shots because she understood the behavior. Yes, the clinician has to have the medical knowledge, but sometimes the knowledge of the person is more, it fits more with the medical assistant because they're more like them, they're more likely to talk to them, reveal their stress, reveal their issues. Okay. Now, here's some other things to look at the clinician 432, and look at the difference. Look, 17% of the patients have eye checks in this full practice, but look at this doc, 49%. What is he doing? And I already told you what he's doing. Sanders doing it. So if we could get the medical assistants in these teams to be more effective. But one of the goals I told you was to discuss how difficult the challenge of our being a team, how difficult it is. So let's now go to show you cost savings, because I think that's pretty impressive. The ADA quality indicators, and we know this is from Bridges to Excellence data. It's all online if you want to get it. What they did was project forward 10 years, and if someone stays at A1C of 7, 10 years later, they save $279 a year, or $279 times 10. So you can see you save more money with blood pressure than you do with A1C. Now, what was the cost savings? And I told you how I calculated these numbers. But look at the cost savings. They saved $500,000 over 1 year. So you can push that forward 10 years and see the savings. Now, it's theoretical through the formula I used, but we know their cost savings. The ADA did this actuarial study. Bridges to Excellence published it. It's powerful data. Now look at the individuals. And the team, 432 saved $171,000 per year. Look how much it was per patient. Look at the difference. Look at the difference. This team was doing something different. Teamwork made a difference. So how I got this number was obviously just divided this number by this number, and then the same along the line. So why should there be that much difference in these positions? And again, don't look at this as one doctor's better than the other, because I'm sure if they take tests, they all answer. They all know the quality criteria. But what is the system that's broken that they need to look at and fix? And don't say it's all patients, because why should these patients be any different than these? There's something that's going on in the system. And you can't say it's the clinic. It's because this team overcame the issues in the clinic. So you have all this data. What do you do with it? You can change. But you're going to change together and devise strategies that address the quality issues. You need a clinician and a non-clinician leader. And leader is an important word. But you have to meet together. And it's not a meeting where the doctor, the residency director, or the head of the office sits up there and talks, and the practice managers talk. Everybody has something to say, and it's critical. So if you have a leader, and a lot of the times the staff person should take responsibility for change, because they're the missing link. They're the ones that are going to make it happen, not us. So we've got to model that in our teaching programs. And I think when a young physician comes into a practice, the chances are they're not going to understand team, because, again, I'll say the residency programs say they do it, but I don't see it, because I see a lot of young people going into practice, and this is a foreign word. They know how to be nice to nurses and MAs, but they don't know how to effectively use them as a team, use population reports, etc. So what can a team accomplish? More and less time, create a better balance between work and life, all these, staff turnover, create cost savings, which I showed you. Now, here's another report. So let's look at this report. Now, these are all fictitious patients. And this is, you have all these reports in your registry if you use this registry. But what is a team-based solution for the gaps identified? So we know, and we could have this for eye checks, foot checks, multiple things. I could say, who hasn't done this the last 365 days? What do? We send them emails? Do we call them? But the staff are going to have to do that. So, you know, they're the ones to give you some ideas. So now let's look at another report. Here's your LDL, and you have this report also for A1C, non-HDL, trigs, and blood pressure. It tells you who's very high. Again, a fictitious report. So these are the very high people. So 58 people, and it's really, we have 108 that really are above 100. But 58 were above 130, so they're probably at higher risk. And let's just look at a patient. This is an actual real patient, and from another database. And you can see the cholesterol at 256, the non-HDL, everything's really high. Everything is really high here. But you'll notice the HDL was high. And I wanted to bring out this point. More and more we're finding out that this is not functional HDL. When you have an inflammatory environment, when these factors are elevated, when you have hypertension, when you have hyperlipidemia, hyperglycemia, the HDL is less and less functional. So there's a lot you can find out by looking at this. This patient hadn't been in since August. They're overdue for their flu shot. So what does a group do when they sit down and they begin to look at these reports? And by the way, you don't have to look at every one of them every time and solve every problem today. Maybe you say, okay, we're going to start making phone calls to people that have LDLs above 130 and do 4 a day, or 3 a day, what have you. Make it small so it's achievable. So now there's another team I want to show you what they did, because they had reports, because they did it. They say, okay, here's where they started out. And you can see the underlying number, 2%, 10%, 6%, 32, 1, 45. I just went through the underlying numbers here. What happened? Look at the change, 59, 82, 63, 76, 66, 65. Why? They sat down as a team and discussed the gap reports. All right, staff decisions were extremely important. They said, well, let's do emails and phone calls, just a few a day. And they also improved the use of report cards. They really said, well, maybe we're not really giving the patient a report card, giving them understanding, and then protocols were developed for use. If the patient didn't have a urine microalbumin, the staff was authorized to get it. They'd have a flu shot and Immunovac staff authorized to do it. It doesn't take an MD or DO degree to ask someone to pee in a bottle or to order a shot, an immunization, which we know is necessary. So I think there are a lot of things we can, as the old transfer med saying is, let's push all of our staff to the limit of their licensing. Why is all this so hard? Why is teams so difficult? Well, there's a beautiful book out called Leadership on the Line by those two authors. You can see the reference at the bottom. And what they said is that everybody's behavior or habits associated with someone or something of high value, a mentor, a parent, religion, prior thinking. So you want to get a patient to change or a staff member to change, there's something subconscious going on. How you know that is you go and you seem like you got agreement, and then you go out and it's not done. Well, I think that's where you get together. I want to recommend a book in a second here called Dysfunctional, The 5 Dysfunctions of a Team, to understand some of the issues you deal with a team. So they'll resist your efforts to preserve what because it's more comfortable. We found that some people felt in our teams that, it wasn't their job. In fact, sometimes when you really push team and have a team effort, staff will leave. And that's understandable because that's not what I came on board for. I don't want to do that. And help them understand the reason for the discomfort. You need to understand it. And we don't want them to give up respect for that value. We'll find out what the value is, but that's really hard. And that's how we differentiate between adaptive and technical change. The technical change is the numbers. We get A1Cs to go from, 10 to 7, or total amount from 50% to 55%. Adaptive is what do they value? What are their behaviors? and adaptive has to come before technical. So how do people adapt? How do you adapt? It's a new way of thinking for clinicians. How does a clinician? How does an office, because many times they feel, well, MA shouldn't do this. Well, who's going to do it? In most private practices I deal with, it's all MAs. Occasionally, lucky if we have an LPN. So we have to go with what we have, adapt to their abilities. You can't do anything that's beyond the limit of their licensure, but there's a lot of things that in a private practice setting or even in a residency setting you have. But in the residency, you usually have hospital rules that make things a little bit more difficult. I think as leaders we have to provide a vision where we want to go, what we hope to do and why, and get them involved. And then allow for passionate disagreement. I think if you read the 5 dysfunctions of a team, that's critical. You'll never get anywhere unless people lay out their issues right on the table, talk about them, and it's okay. I disagree. Okay, help me understand that. Okay, how do we get through that? What do we do? You know, when you may end up saying we agree on the fact we disagree, and we have to move forward and have to get some type of commitment because we can't be that nothing's going to go forward unless we have 100% agreement. Give the work to them. Their norms, vision, and culture has to be incorporated rather than you as the leader of the program or the position saying, well, why don't we do this? Say, here's the problem. Staff, what do you think we should do? What would you do? And that's going to be very hard for them. First, they're not used to it. And what you got to do is learn to keep your mouth shut until they come out with a suggestion. Well, they work collaboratively with you at the expense of their autonomy. And we all like our autonomy. Different clinicians, we all like to have our territory stepped on. Some of them don't want their territory stepped on. Maybe the nurse feels that's her territory, and although she can't do it all for the whole practice, the RN, she's not going to give it up until you allow it to be her decision. The people with the problem need to be the people with the solution. Again, I'm quoting this book here, Leadership on the Line. So change. It can overwhelm a practice, creates change fatigue, unresolved tension, conflict, burnout, turnover, passive and active resistance. So where did we learn all this? The American Academy Family Physician National Demonstration Project, all published. I think Nutting was the author of this in Health Affairs, just recently published in the last few months. So this is what happened when the practice has got to change a whole lot. And then what they talked about is a word I really liked, adaptive reserve. And what they found was that practices have an internal capability for organizational learning and development. They were more successful. So what's the adaptive reserve? And I found out when a practice wants to do this, when a residency program wants to do this, if they don't have any adaptive reserve, if they don't have an organization, an environment, an organizational learning environment, it ain't going to work because we're trying to put in something that's completely foreign. So anything you're going to do to improve your quality, you've got to look at your adaptive reserve. So how do you check it out? And this is something Anton Kuzel published in Family Practice Management here last May or June. Anton is the professor and chair of family medicine in Richmond, at the medical school there in Richmond. So how confident your patients in managing your care? Here's the things he suggested. You have regular team meetings. The staff members feel empowered because their opinions drive the practice decisions. They have to do that. How well is the practice performing on measures relating to preventive service delivery and chronic disease management? And then the last thing, Dr. Kuzel suggested, you have a patient advisory panel. It doesn't mean that they'll tell you what to do, but I like sitting in waiting rooms in physician practices. Sometimes they haven't told the staff that I'm coming in. I'm supposed to be there for, say, a noon lecture. I come in a little bit early. I sit out in the waiting room. I like to listen to people talk. And they'll ask me why I'm here. I'm just here, to visit with the doctor, not about a patient. Oh, what do you want? Okay, but I ask them, what do they think about the practice? Wow. Do they tell me a lot? They'll tell you. I don't know how effective it is or what it is, but they have opinions, and we need to listen to them. Suggested reading, and there's a big, long web address. Rather than do that, if you're interested, just Google participatory office. This comes right up. I Googled it this morning, and this article comes up. Wrote it in April. A lot of stuff I'm talking to you now about is right in there. Also, this is our website, Master Clinician website, published articles, and you can go on Google Diabetes Master Clinician. They'll come up, and just a lot of articles. This is the one, I think, most recent. And, diabetes registries and teamwork, keys to the patient-centered medical home, that if you click on this, the article comes up. So any of these articles you want, and there are many other that have been published you could look at. And here's, again, this article right there. And then here's the 5 dysfunctions of the team, a leadership fable by Lencioni. And you can go on Amazon.com. I'm sure other bookstores have it. You know, you can see you can get it new for $8.90, used, acceptable, collectible. I don't know what that means. But anyway, you can just buy one. I bought one, mine about a year ago. It was $20 then, but pretty inexpensive, you know, not very difficult. You can click and read a couple of the pages if you want, but nice common sense. It's not written for physicians. It's written for businesses, but I think it's very applicable to us. So what have hopefully I've done here? I hope I've discussed the value of measurement and registries, how it relates to PPACA and PCMH, and again, how it relates to Patient Protection and Affordable Care Act is everything in the medical home is part of that new legislation. Measurement, transparency, cost effectiveness, et cetera, et cetera. Unfortunately, if you listen to cable news networks, they talk about the issues that are very politically charged and not about these issues, which are part of that. And I think they have bipartisan support, and we have to look at them. And I think we have to make them better. No act is perfect when it's first created. We have to make it better because we have to see how to implement it. I discussed registry reports from our Master Clinician program, how you might use them. And then I stressed a lot team care, why it's so difficult. Then I gave you a few examples of participatory office teams and how they increase quality. And I showed you how they increase cost savings. Yeah, within a practice, one physician created the majority of them. And then, above all, I hope I've encouraged you to think systems, population-based solutions, and staff empowerment. Because I think that's where we are. It's theoretical, but I've tried to make it come down to practical with some of these things. Thank you very much for your attention. I'm very willing to take questions, comments, et cetera. And that's it, Susan.
Thank you, Dr. Shahady. We appreciate your time and certainly your expertise. I am going to see if there's a way to make sure that we can get any questions. And again, I apologize for some of this new technology. I do see that we have a couple of questions, and let's see if there's anything for Dr. Shahady specific. If you'll notice over in the Q&A section, you can type in a question, and we'll wait a few minutes while people do that. And then Dr. Shahady can respond to those. But again, while people are typing in their questions, please know that this webinar was recorded, and you will be finding a link to that that'll be posted on our website so that you can share it with colleagues. Additionally, I think we may have our team coordinators go ahead and email the link to let people know that it is available. And the other announcement is that we have plans to have the team coordinators send out letters, emails to everybody by the end of the week, announcing the recruiting efforts for the Diabetes Registry program, the Diabetes Master Clinician program. And that will be an email that you can look at, and there'll be an attachment to it, and we ask that you work with your colleagues to determine if, in fact, your residency program or your private practice is interested in participating in the Diabetes Master Clinician program. And we've given you about 6 weeks to process that and come to an understanding and an agreement, and then return that letter to me at susan@godiabetes.org. And I don't see any additional questions. So please know Dr. Shahady is available if individuals have questions. His phone number and email will be in the letter that we send out. And as always, please contact your team coordinators if you have questions. We thank you for your participation in this event. Thanks so much.